if you haven't downloaded the Poll Everywhere app, that's the information you need. So you do need your phones for this session or a tablet. Just put it on Do Not Disturb or turn the sound off or something.
Right.
Thank you.
All right, we're ready to go? Thank you very much. I'm losing my voice. Welcome to this vaccine session. I don't see any telehealthers there, but if you are there and just invisible, welcome to you as well. And of course, welcome to the WebExers. So my name is Stephanie Stevenson. I'm the Executive Director of the BC Pediatric Society. For some reason, I'm losing my voice, so I'm going to be going to quit talking very soon and turn it over to Laura. Thank you, Laura.
Okay, thank you. So let's just see here. So this is part 2 of the session on increasing immunizations or increasing immunization uptake, particularly geared to pediatricians and consultants who may or may not be immunizing in their office. The intention is that you'll be more confident in your role in discussing vaccination. You will know exactly what you're supposed to do when reporting adverse events following immunization. You'll be giving some tips on talking to vaccine hesitant parents and their children. Sometimes it's the kids that are vaccine hesitant. And to understand the interface between public health, pediatricians, primary care, and pharmacists in preventing vaccine preventable disease. So on your audience response system, the Poll Everywhere, to join the presentation, you enter Laura, L-A-U-R-A, Moore, M-O-O-R-E, then DE051. We're going to be using this for, well, first I'm just going to test it to make sure you've got the idea. We have 24 WebExers that are registered. We have, I believe, 4 telehealth, and there were 14 registrants for here. So just not sure how many numbers will come up, but that does show us. So if you can enter that now. If you joined last week, you don't need to re-enter the whole thing. It should, you don't need to sign in or register again. You just need to sign in. So is everybody okay with that? Do you want me to leave this up for a second? Okay, I'm just going to leave it up and I'll keep talking. So this program, last week and this week, is being sponsored by GSK because we at BC Pediatric Society signed up for a grant or applied for a grant, which we were very pleased to be successful on. There's been no affiliation with GSK at all, other than it was completely hands-off. There's nobody here from GSK, and so I don't know if you call that third party, whatever. So just so you do know that. Are we okay with the sign-in?
Getting presented on phone.
I have the same.
Well, am I signed in?
Yeah, I have it.
Okay, well, we've got it here, and you've got it there.
Yeah, favorite season.
Yeah, that's the one.
Yeah, favorite season.
Okay. All right, well, okay, let's get out of there and do that.
Get there, here.
You're not going to try and make me learn something, are you?
No. So we're gonna test, right?
Yeah, that's the test one first.
Okay,
Test is
so
what's your favorite season?
exactly. Active full screen.
Yep. Should be good. Right?
Show result.
Yeah.
There you go.
Okay.
Next.
Okay, here's the next one. I've used audience response systems before. Never? Wow.
Yes.
Okay.
Old fashioned, just show
Next
hands.
one. Show result active.
Okay. And has anybody used the Poll Everywhere audience response system before? Last week. Okay.
Okay.
All right. So I think you've got the hang of it as long as you're signed in.
Oh, okay.
Okay.
Uh-huh. All right, so I'm going to be the timekeeper tonight. And just to remind everybody that the session is scheduled to go till 9:30. Last week we finished at 9:30, but pre-evaluation and post-test and completing the commitment to change. This week, we're going to complete all that before 9:30, and hopefully we'll be out of here with the evaluations completed by 9:15 at the absolute latest, because I do know it's important to respect everybody's time. And I think that we'll do the pretest.
Okay.
Okay? It's not the same questions as last week. Okay, so parents are most concerned about effectiveness of a vaccine when deciding to immunize their child. True or false? Oops. Okay, we've got two results. I know there's more than two people here.
It just won't load. Presenter not found.
How is it? Is it loading now? Yes?
I'm just sending you texts.
Okay, well, texts are fine. I accept that. Okay, I'm going to go on to the next question. Okay. Okay, Jackie. Okay, never mind, found it. It is important to completely disclose spurious side effects attributed on social media to a vaccine if the parent has not mentioned it. True or false? Excellent. Okay. All right, next question. By establishing a good, trusting relationship over time, many parents will allow their child to receive at least some vaccinations. It's not, Jackie? It's not on the screen.
Sorry, we're just having a small technical problem for a moment.
Okay. Are we there now? Thank you for telling me, because it's on my screen. And I want to show results. Okay, I'm going to keep going because time thing. Okay, full screen. Pediatricians are required to report adverse events following immunization. Is that on the, yeah, okay, there it is. Okay, next. Oh, I forgot to do the show results for that one. I'll do it for this one. Okay. All right. What are limitations of passive surveillance for vaccine safety? Non-reporting, underreporting, not representative, all of the above.
We can't see
It's
anything.
gone away again.
Well, we can see something, but it's not.
But it's not what I'm talking about?
No.
It's not about.
The access code is 809921147.
Okay, well, you should be seeing it. Oh, that's, okay, well, you know what? Let's just wait 1 second.
It's there.
Is it? Oh, I was just gonna have a sip. Okay. The limitations of passive surveillance for vaccine safety: non-reporting, underreporting, not representative, or all of the above. 4, 5. Okay. Okay. Show results. Full screen. Is that showing? Injection site reactions? Okay. What types of adverse events following immunization should not be reported? Check all that apply. Injection site reactions, death, anaphylaxis, or headache. Okay. Next one. Okay. A strong recommendation for vaccination is the most important thing I can do to increase vaccine uptake. True or false? Why is it not showing me there? Okay. Great. Many vaccine hesitant individuals do not trust the healthcare system or have had negative experiences with the healthcare system. True or false? Okay. Huh. I don't know. Right. Next. Some people who are not vaccinated are not hesitant.
Access, man.
Okay. Next question. The proportion of parents of school-aged children who choose to forego all immunizations is approximately 2%, 5%, or 10%. Oh, still some either new info or... Okay. In BC, infant immunizations are provided by public health nurses, physicians, pharmacists, A and C, or 1 and 2, or all of the above. Okay, we're almost finished. Effective ways of improving immunization rates in school-aged children are A, multiple opportunities to immunize, immunization requirements for school entry, immunization education for parents, or all of the above. And parents are most concerned about effectiveness of a vaccine. Oh, we had this one. Okay, so we must have restarted this.
You're done.
Right. Okay, usually it tells me that, but anyway, okay, so let's just escape from that. I'll do that. Okay, so Did you want
My
to?
turn.
Yeah. So we're going to come back to that and repeat that test at the end. By that time, everybody will be all good on their phones or their tablets.
Hello, everybody, and you out there and the rest of the province. I'm Avon Pointer, President of BC Pediatric Society, and a minor player in the planning of this course, and welcome. Actually, before I start, I know I'm not going to hold things up. Last week I spoke about brief interventions in hospital and office setting. And to encourage parents to immunize. And I just have to tell you, I have one that happened today, last week, not today, and last fall. I saw a little fellow, he's 5 years old. He had started kindergarten, and I saw him for his first consultation for asthma. The disclaimer is I already had a relationship with the family because I had seen his older brother for a few years, and I had also seen this little fellow when he was a baby, but this was a new consult for asthma. And so where's your little boy? I'm doing his full history with his immunizations. Mom says, well, he hasn't had his kindergarten booster because he hates doctors, nurses, and needles. And I said, oh, well, there's a measles outbreak in Whatcom County right now, and that is just a few kilometers south of Langley. I think it would be a really good idea if you went and got his measles booster. So that was during the history, and then at the end, when we're talking about his asthma and what we're going to do about it, I said, and so just again, mention, it's a good idea to go get his kindergarten booster shot. And as I mentioned last week, then I put it in my recommendations in my consult letter. And I saw him today for his follow-up visit a few months afterwards. And I go into the exam room and Mom and he are there, and she says, well, we went and got his measles booster. So it was easy, it was fast, probably it took me 3 minutes. As I said, I already had a relationship with the family and they weren't anti-vaccine, but they had delayed it. And now I'm pretty sure she's happy that she got his measles booster. Our first speaker tonight is Dr. Julie Bettinger. She is going to be talking to us about vaccine safety monitoring in Canada. Dr. Bettinger is an associate professor at the Vaccine Evaluation Center in the Department of Pediatrics at UBC and a Michael Smith Foundation for Health Research Scholar. She's an infectious disease epidemiologist whose research interests include vaccine safety and vaccine preventable diseases, specifically meningococcal and pneumococcal invasive infections, as well as attitudes and beliefs around immunization uptake and use. Dr. Bettinger is the Data Center Director for the Canadian Immunization Monitoring Program Active, that's IMPACT, you've all heard of that, an active surveillance network for vaccine preventable diseases and vaccine adverse events. She is also the lead investigator for CIRN's Canadian National Vaccine Safety Canvas network, which monitors the safety of influenza vaccines each year. Dr. Bettinger?
Great, thank you. Very happy to speak with you tonight. So I'll start with my disclosures. I don't have any relationships with commercial interests, but if anyone wants to give me money, I'm always open to that. I do have relationships with government interests. So I get grant funding from the Canadian Institutes of Health Research, the BC Immunization Committee, and the Public Health Agency of Canada. And I do have relationships with nonprofits. As mentioned, I've got a career award from the Michael Smith Foundation, and I'm on the scientific advisory board for the Meningitis Foundation. So my objectives for this talk today are going to be to define vaccine safety and monitoring, or surveillance. You'll hear both of those words used interchangeably. Oh, hold on a second. It's doing its own thing. Yeah, no.
No slideshow. Cannot do the note.
No, I don't want it to advance automatically. That's what I'm trying to change.
Kill the timer. Yeah, here you go.
Yeah.
Got it.
Yeah.
This one?
Yep. Perfect.
Okay.
I talk fast, but not usually that fast. So, okay. So to start with then, vaccine safety is the detection, assessment, understanding, and communication of adverse events following immunization, or AFI, and the prevention of unintended effects of vaccine or vaccination. So it's an assessment of vaccine safety, or an assessment of vaccine safety is really essential because what it really does, we do it before vaccines are approved. So that would be happening in preclinical trials before the vaccine is used in the population. But preclinical trials, you usually select healthy volunteers. It's usually a very narrow age range of participants, and they don't have underlying health conditions. When we approve a vaccine for use, a lot of that changes. It's generally approved for a wide age range, and oftentimes is given to people with underlying health conditions. So we're using it in a slightly different population that may not have been included in the clinical trials, and we really want to make sure it's going to work the same way it did in those clinical trials. So that's what we do. That's what we would call post-marketing surveillance when we do this type of monitoring after the vaccine is approved. It also, each vaccine lot is prepared, manufactured, and so you need to make sure that the quality assurance is there. We want to monitor for that. And then you also can have adverse events that occur in terms of vaccine implementation or delivery. And so our vaccine safety system needs to be able to capture those types of things, and we need to be able to watch for them. So there are some objectives to vaccine safety monitoring. One is to measure adverse events following immunization, or AFI, to monitor trends, so vaccine failures. If we start to see a lot of people who were immunized but suddenly getting infected with the disease, that may be an indication that our vaccines aren't working in the way that we thought they would be, and maybe there's something wrong with the vaccines. It can also be used to guide program planning and implementation, evaluate public immunization programs, and prioritize scarce healthcare resources. So there are many different methods you can use to measure vaccine safety. There are observational studies. So these would be cohort, case control, screening method. I'm not going to focus on these in great detail today. These you would often use sometimes if you get a safety signal from our surveillance system and you want to investigate it a bit more closely. What I am going to focus on is surveillance. And this is really the ongoing systematic collection, analysis, interpretation, and dissemination of vaccine safety data for use in public health action. And this is really what we do most commonly with our vaccine safety monitoring. So there's a few things you need to be able to do this correctly. First is a case definition. So what is it that you're actually looking for? Is it GBS cases? Is it headaches? You need to be able to find what it is so that you can identify it, because the next step is case identification. You have to be able to find these events when they're occurring. And then it's important to have vaccination status ascertainment. A lot of our safety systems sort of start with the vaccine and then look for the events. In an ideal world, we would actually be capturing all of the events and then determining whether or not the individual is immunized, because then you actually have a control group that you can compare to your vaccinated group. That's a bit more difficult to do. There are some systems, HMOs in the United States are a great example of that, because they sort of have a contained database where they have people who are vaccinated and people who aren't, and they can sort of look for events and then look for their exposure history. But what we do a lot of, and what is most common, is really to look for these events after someone's been vaccinated and collect them. If you do have a control group that you're able to use, it's really important to make sure that that control group is similar to your vaccinated group, because as we're going to hear a lot of tonight, most people are vaccinated, and so therefore sometimes that group who opts out of vaccination or who isn't vaccination can look quite different, or who isn't vaccinated can look quite different than the vaccinated group, and they may not be a good comparator. Okay, so there's really three main types of monitoring that we do for APHIs. The first is passive surveillance, the second is active, and the third is sentinel, and I'm going to describe each of these. So passive surveillance is probably what you're most familiar with. These are events that are reported to health authorities in Canada by healthcare providers, so pediatricians, GPs, public health nurses. And they report these when the case occurs. So if you have a patient who comes in to see you and says, oh man, after that last vaccine, I was sick for 2 weeks, or I was paralyzed, you'd want to report something like that, right? So, that's likely how you're going to hear about those. But there's other systems like in the UK and the US where individuals can actually report into them. So if I have an event after my flu shot, I could actually report that in the US into their system. And the UK, it works similarly. This is the least costly method for monitoring, but also one of our perhaps least complete. So some of its limitations are non-reporting, underreporting. It's underrepresented. It can be underrepresentative and has oftentimes very limited clinical detail. You're essentially asking healthcare providers to let you know about this, and so the level of information you can ask from them is sometimes limited. Some examples I've got down here, all of our provincial APHE reporting systems work this way across Canada, and they feed into the national reporting system, which is called CAFIS, or the Canadian APHE Surveillance System. And then it would be VAERS in the United States, which is the system I mentioned where both healthcare providers and individuals can report. So active surveillance is a little bit different, as you may guess from the title. You actually conduct outreach to find the cases, or you do something like perhaps send someone an email to prompt them to report to you. You're not just sitting there waiting for the cases to come. You're actually doing something to try to generate case reports. So this can take the form of sort of active case searching of hospital records, laboratory reports, discharge summaries. Obviously, this is more resource intensive than passive surveillance. We don't do this a lot, but it can be done sometimes in special circumstances or, in smaller groups. It is more representative than passive because you're actually looking for everything that's happening, and oftentimes can be a lot more timely. Some examples of this are the Canadian National Vaccine Safety Surveillance Network that I'm involved with for influenza surveillance. But I can tell you it's very resource intensive. It's quite timely, but it takes a lot of work. And, it would be quite difficult to potentially do this for every vaccine given in Canada. Another great example is VaxTracker, which is in Australia. And they're actually reaching a point where they can do this more for all of their vaccines because they've really been able to make it electronic. And so has really made it much more doable. So I think moving forward, we're probably going to see have an ability to do a lot more of these sorts of active surveillance systems as we move to more electronic records and electronic reporting. So sentinel surveillance is where you do monitoring in selected groups or populations, and it's ideally, if you set it up right, the population that you're looking in will represent the entire group. So you want to sort of create a catchment area of people that look like the whole population if you can. It's really important to use standard case definitions and protocols. This is true for actually all of the types of surveillance, but particularly with Sentinel because you're looking at it in smaller groups and you want to make sure that everyone's doing it the same way at your different surveillance sites. So great example of this is Impact, which we've already talked about, and I'll give you a bit more details on Impact because I'm directly involved with that and can really speak to it. But there are some other examples in the United States, the Sentinel Initiative and the Active Bacterial Core, or the ABCs. You may have heard of that or certainly seen publications from that group. So I think everybody knows Impact is in 12, let's get them all up here. Need one more there. Yep, 12 tertiary care pediatric hospitals across Canada. It started in 1991 and has been going now for about 28 years and captures about 90% of our tertiary care hospital admissions and covers about 50% of the pediatric population. As I said on the earlier slide, you really want to make sure it's representative. You can probably look at the map and maybe guess where Impact doesn't represent all of the Canadian population very well. We do really good in sort of urban areas, which is based on where our tertiary care hospitals are located, not so great in rural areas, and we really don't have any representation, obviously, up in the territories. There is another surveillance system in place up there, somewhat similar to Impact, a bit more passive. So it's not as if there's nothing going on in the territories, but I think it's important to sort of point out some of the limitations that we have with this surveillance. So the way it works is that we actually pay nurses to go and look for cases, to look through admissions at all of these hospitals. And then there's an infectious disease pediatrician who serves as the investigator for the site and makes sure things are running correctly. And they volunteer their time for that job. It's not completely voluntary because they do get some academic kudos. We try to publish what we find with the data. So there is a bit of that sort of quid pro quo, but they probably volunteer a lot more time than they actually get out of it. So we're quite lucky to have people who want to be involved with it. And so the way it works is that our nurse monitors actively look through every admission that comes in for any of the conditions that we have under surveillance. We do both APHEs and we do vaccine preventable diseases. I'm going to focus on just the APHEs today. But once they identify, say a seizure case, they will go in a child that was admitted, they'll go review that patient's chart. At some of our centers, they're able to actually start with the immunization history and then just look at those kids who had an immunization within a certain window. We have that defined for the different vaccines. But at most of our centers, they actually have to start with the event, so the seizure, and then go back and see, was that child vaccinated? So it's a bit more work for those centers where they have to do it that way. And then all of the data comes into the data center here in Vancouver, and also goes, for the APHIS, goes on to the Public Health Agency. So what we look for, because you can imagine if we had to search the immunization history on every single child that was admitted at the 12 centers, it would be completely overwhelming. So it has been narrowed down to, and probably completely unaffordable actually, but it's been narrowed down to sort of the events that were felt to be the most serious and the ones that we wanted to make sure we were capturing. So primarily neurological events. You can see seizures, both febrile and non-febrile, encephalopathies and encephalitis and ADEM, myelitis, GBS, and any other type of acute flaccid paralysis, thrombocytopenia, intussusception, and then we do have sort of another category. So if something comes in that's just unusual, it can get reported. So these graphs here, I'll see if I can, do we have an error? Yeah, okay, good. So you can see the blue in these graphs are reports that come in from the passive surveillance system in Canada, and this sort of pinkish, reddish color down here are reports that come in from IMPACT, and these are in children younger than 18 years of age. And you can see just looking at this first graph here that clearly IMPACT is reporting a very small percentage of the overall APHIS that get reported at a national level. It accounts for about 4% in total. So in terms of actual quantity, not a lot, but when you look at severity of the APHIS, and that's this graph over here, you can see that actually IMPACT's representing over half of all serious APHI reports. And when we look at just neurologic events, it's 70 to 90% of those. So it's doing what it was designed to do, and it's capturing the serious things that are being admitted to hospital. So how does the APHI reporting process work? And people may know this already, but I think it's kind of important to understand. Okay. Oh yeah. Oh, they don't have those yet? Yeah. Oh, yeah. Oh yeah. No. Yeah. Definitely pass them out. Yeah. We're not quite there yet, but yeah, that would be good for them to look at. So the APHI is identified either in the passive surveillance system, so it would be you or another healthcare provider, or by IMPACT. And I should say here, if any of you are at BC Children's Hospital, IMPACT will look for these. IMPACT reports these for you. So some of my next few slides, you can just sort of say, thanks IMPACT. But if you're seeing patients somewhere else or you have your own clinical practice, then you would be that healthcare provider who needed to report them. So it gets identified, and then the healthcare provider or IMPACT reports it to local public health. And local public health will then review the APHI and enter it into an electronic registry. And then if necessary, depending on what the event is, the medical health officer, or in some jurisdictions, some public health nurses can perform this duty, depending on, again, what the event is and the jurisdiction. They can provide a recommendation for future vaccination. And then from there, the reports go to the BC Centers for Disease Control. So sort of they aggregate up to a provincial level where they review that data weekly. And they're looking for clusters of events or serious events. They're kind of looking for signals when they get all of this data together. And then BC CDC submits the provincial data on to CAPHIS, to the national, to the public health agency. And then nationally, they compile it, and they will also submit it on to WHO. So it's kind of then goes internationally. Adverse events following immunization are quite rare. Sometimes we're talking 1 in a million, 1 in 3 million. And so, with those types of rates, it's very difficult to detect really, really rare things, even if we look at the entire population of Canada. So there's a real effort to sort of be doing this on a global basis and everyone using the same definitions. And sharing information so that if something is super rare, we will be able to detect it in the information that we have. So I was really excited to see on the test, the pre-test we did, that everybody knows you should be reporting these. That was one of the points I was going to try to make with my talk, but I think everybody already knows that, which is great. The legislation recently changed as of this year. If I put the link on here if you really want to go look at it, but you already know you're supposed to be doing this, so I won't spend any more time on that. I will touch a little bit about what you should be reporting. You can report anything, but public health is most interested in any unexpected or serious events. And this would be events that require medical attention, are life-threatening, or cause death. So the categories collected, and there was just a form that went around. So you can actually look at the BC reporting form and see for yourself what the categories are on there. But essentially they're allergic, including anaphylaxis, neurologic events, and any other sort of notable, serious, or really unusual event. So take a look at the form. That gives you the best idea of really what they want you to see. There's some things that they don't actually want you to report. One is a local injection site reaction. And by that, I mean, anything that doesn't pass a joint, right? So if someone comes in and their entire limb is swollen, from the shoulder down to their fingers, that's not a local injection site reaction, okay? That is something you could report. But anything that doesn't pass a joint, it's expected. We know that happens from vaccination, and we don't really want to track those types of things. Also, unspecific systemic events, so headaches, myalgia. Again, this is actually an expected response to a vaccine. It's not worrying. It's not something that we need to be, putting into our AFI system. And then an event with an obvious cause. So if someone is paralyzed, they got their flu shot the day before, and they're paralyzed the next day, but they were in a car accident, don't report that. That and the paralysis is due to the car accident, right? I guess I should clarify, not the flu shot. So I was trying to think of a good example. That may not have been the best one, but if there's another cause, a clear other cause, that's not something that should be reported. You're all clinicians. You'll have a much better judgment of that than I will. So I will leave that in your hands. But just to give you some guidelines, there's also, actually, let me just jump to the next page here. So BCCDC has done a very nice job on their website. This is I've got the full link up here. But it's in their health professionals section, and it will give you essentially the information you need to be able to do this. It explains what an AFI is, it shows you where to get the forms, and then I think what's really helpful, so here it says, here's where you download it, you can complete it, mail or fax it, and then it has this little thing of where you need to send it in. If you click on that box, it gives you a whole list depending on what your location is, where it needs to go. So I think they've tried to really make it easy for you. There's also, you can contact them if you have questions. So I'm not going to go into great detail on this, but this is where you find the information if someone comes into your office and you need to report something. So I think in conclusion, there's sort of three main types of surveillance that we do in Canada for vaccine safety: passive, active, and sentinel. And it really provides us assurances that our vaccines are working the way we expect them to, and that our vaccine programs are safe. It identifies specific serious adverse events and contributes to other methods for us to be able to evaluate immunization programs. And the one thing I did want everybody to sort of take away from this is that as pediatricians, you all play a really important role in informing us of these events, because if a patient comes in and tells you about it, there's no way that public health will know about it unless you tell public health. So you do have a very key role in this system in making sure that it works. And I do just want to acknowledge Dr. David Shifley. He's one of the founders of Impact and has been a really big mentor to me, and obviously contributed some of the information that's in these slides, and as well our Impact nurse monitors and the other Impact investigators. Whoops, those were my questions, which you already got. So yeah, and do we take questions or how is that? Yeah. Okay. Any questions?
Yeah, is adverse event reporting improved by giving parents a clear set of reasons why you'd want them to report, or is that done in any?
I don't think that's done in any formal, certainly with impact, we're not doing it that way because we're just looking at what comes in and then did that child have a vaccine. But I think as a clinician, there's studies that have shown, particularly around the meningococcal B vaccine, which is somewhat of a reactogenic vaccine, or more so than some of our other vaccines. When parents were told, expect fever, here's what you do if your child has a fever, they were much less likely to be worried, and they may or may not have told the healthcare provider about that fever if they weren't worried about it. But I think providing parents with guidelines of what to expect regardless is helpful. And then, you can tell them, let me know if any of this happens, and they can come back and tell you that as well. But I do think, in wearing my other hat of sort of why people choose not to be immunized, oftentimes having an AFI is a worrying enough event that may push them over to the hesitancy side. So I think that sort of communication is really important with patients.
Any other questions? No questions from far away. I have one question. The Canadian Pediatric Society has a surveillance program, and they send a questionnaire out every month. Is there any possibility of using that for something that's sort of between passive and active surveillance?
Right. So that's CPSP, the Canadian Pediatric Society
surveillance program.
Is that what? Yeah. Okay. Yeah. So they have set that up to really be for very rare. It's not even events, but very rare diseases. And so I think it's not for things that we want to monitor as actively, and it's more, my understanding is it's more for things where we're trying to figure out what's going on and what it is. And I think, to be honest, it would be very difficult for that to replace what we have with impact, given that impact is. Oh, okay.
I meant add to.
Add to. Well, it would depend, actually. That's an interesting thought, because maybe you could get it. I think it would be too much overlap in the hospitals where there's already an impact nurse. But impact is only working in what's
the tertiary
collecting.
Level hospitals.
Yeah, exactly.
50% of the kids, as you said.
So that's actually, I hadn't thought of it that way. Yeah.
So many of the CPSP, I think, vast majority of pediatricians who would respond would be community pediatricians.
Yeah.
The vast majority of whom may not be working in a tertiary level hospital.
Yeah, no, that's a really good point. So the question would be, you'd probably want to keep it very focused.
Yes.
And very short, is more like a passive surveillance system, because that would be asking, our impact report forms are pretty detailed, and I would hate to be sending that out to,
Well, they send out the question, if you respond yes. I had to respond yes to once, and then I got the detailed form.
Right, okay.
I've been sure to respond no ever since.
Yeah, exactly. Well, exactly. So
no, I haven't.
I think you would want to be very circumspect about the questions you were at, and very focused in what you were asking about, so that you would still get people willing to participate in it. But that's an interesting thought, because maybe for something that we were really concerned about, or a signal, or something we really needed more information on, and we needed it outside of our existing centers, that might be a good way to capture it. Yeah.
Thank you for that. You could do it for a year or 2 years.
Yeah, exactly. That's usually what the CPSP is. That's usually about what they do. They do it for about a year or two.
Yeah. Yeah. Thank you very much. Our next speaker is somebody's going to help with the slides, right, Jackie? Is Dr. Rika Gustafson. And Dr. Gustafson is going to talk to us about immunization program delivery by public health physicians and pharmacists in the health authorities. Dr. Gustafson is a medical health officer in Vancouver, associate clinical professor in the School of Population and Public Health at UBC. She's a frontline public health physician with experience in communicable disease control, overdose response, maternal child health, which means everything.
I don't do environmental health. I don't do water systems. So there you go. Hi, everybody. Nice to see you. So I'm going to talk to you. I've no conflicts to disclose. I'm a public health doctor, people. But I describe my learning objectives as describing the current state of immunization programming in VCH, because that's what I'm most familiar with, but also in other health authorities, to identify some of the challenges of a complex immunization delivery system and discuss working together to protect the population. I'm going to spend most of my time on the last bit. Immunization programs are, of course, a combination of those who are being immunized and the immunizers themselves. And one of the things that's a bit of a challenge in British Columbia is that our immunization system is actually highly varied. Again, I'm going to talk a little bit about Vancouver Coastal Health because that's what I'm most familiar with. Right now in Vancouver Coastal Health, children 0 to 1 to 2, about 50% of immunizations are given by public health and about 50% by physicians. And that's actually quite a substantial change over the last decade or so. When I started, it was probably about 10 to 20% given by public health. So there's been a real shift in my city towards provision of vaccination by public health. By kindergarten age, an increasing proportion are done by public health and, of course, school age programs, which are given in kindergarten and grade 6 and 9, essentially 99. So essentially 100% are done by public health. I do not know why I have that to two significant figures. I think probably for physicians, one of the most important things to know is when public health goes into the schools. It goes in kindergarten, it goes in grade 6 and grade 9. So if you have a child in front of you that's just arrived to Canada and they're, pardon?
To go in kindergarten?
Pardon? Depending on the jurisdiction, we either have them come to the community health center or we still go in kindergarten, depending on the area. You're quite right. But the important thing is that if you have a child who's arrived to Canada in grade 2, it is important that not to assume that a school nurse is going to come in anytime soon. It's going to be in grade 6. And adults are immunized by a combination of public health physician and since 2009 pharmacists. Pharmacists are licensed to provide injectable vaccines to children 5 and older, and they can have the nasal mist for children 2 and older. Practically speaking, most pharmacists self-select to provide vaccinations to older children and young adults. We don't get a lot of vaccinations provided by pharmacists for young children. Again, the immunization program delivery varies by province. In Northern Health, they have moved to the primary care network. So they're, in fact, all immunizations are provided by primary care network. They're even responsible for their school immunization programs. In Fraser Health, about 75 to 80% of public health and 20 to 25 by physicians over all programs. They weren't able to cut, divided for us. In Interior Health, about 100%, essentially all childhood immunizations are provided by public health. I didn't get any data from Island Health. So I think just really what I'm trying to get across is that it varies. So if you think you know your region's immunization system, then you know your region's immunization system. So if a child is coming from somewhere else, you actually don't necessarily know who immunized them. So because of these complexities, there's some challenges and success of a complex immunization delivery system. And some of the challenges are number of vaccines, communication between all of these providers, keeping a patient record that is going to last them a lifetime, and then vaccine supply, such as multiple vaccine products that change every year, and the arrival date changes every year for influenza. And then for most other vaccines, actually one of our challenges is cold chain among all of these individuals, some of them who are extremely well poised to maintain cold chain and others not. So I actually put some questions up, but this isn't on your fancy schmancy thing. So which probably has a name. But a little bit about the complexity of vaccines. Just guess how many vaccines were in your head. How many new vaccines were added to the routine childhood vaccination schedule between 1972 and 1999?
Yeah. Man, hepatitis.
So the answer is 4. Only rubella, MMR, Hep B, and Haemophilus influenza. And then, how many new vaccines have been added since 1999? And the answer is 7. MenC, pneumococcal, varicella, HPV, rotavirus, inactivated flu, and meningococcal. And this is the routine vaccination. So that move from physicians providing lots of vaccines to less and lesser is to some extent affected by this. This is a really great thing. I just want to, when we talk about the complexities, and I'm not going to go into the dates, but for example, look at the hepatitis B reported cases when the infant immunization was introduced, as well as essentially the disappearance of meningococcal C disease in our population after the universal introduction of meningococcal C vaccine. So it's important when we talk about how complicated it is. We're doing this, of course, for a reason. And I always like to remember that's my little girl who's no longer that little. And those are the diseases she doesn't have to worry about. That's one generation of vaccine development. You know all this, but I think it's important to reflect on it for a moment of what we've actually achieved. She gave me her consent to use this photo when she was 5. I haven't asked her since. That is not mature minor consent. Anyway, the other really challenging part is communications. There's many players. There are many immunization providers. There are other healthcare providers who need to know your immunization record, who have nothing to do with the immunization provisions. And this is the one piece of health information that childcare centers need to know, that schools need to know, that workplaces might need to know, the patient themselves needs to know when they're traveling. And sometimes when it's yellow fever, even the border agency needs to know. So immunization record communication is actually, it's a relatively simple health intervention, but the communication of that it's happened has to occur across sectors that most other health information does not. There are different providers and a mobile population. They're evolving electronic health records, both in physicians' offices and in health authorities. But despite all that, we actually have some very good immunization record system. And I'm going to talk a little bit about Paris because I'm from Vancouver Coastal Health, but there are other. Panorama is one of them. Public health loves to talk about my system is better than your system. I'm not going to talk about that. I'm just going to talk about having a system. And of course, I think the important thing in the future is going to be a patient portal, such as Can Immunize. So an example is Paris. Again, for you to know, Paris is a public health information system. It's being used in Vancouver Coastal Health and Fraser Health as well. Increasingly, and public health nurses populate and upgrade children's immunization records in kindergarten, in grade 6 and grade 9. That's actually really important. For many, many years, public health went into grade 6 and gave whatever vaccine they were given, hepatitis B vaccine, or whatever it is that they were given. They didn't actually have the capacity to look at what other vaccines that child had. So one of the really important parts of an immunization record like that is that it supports what we call immunization by history, and which means that I immunize you based on what you've had, not just what I happen to think is due in grade 6. Not all of the province is there yet, so that's really important. So don't assume that if somebody got a vaccine in grade 6, that means they necessarily got updated in all their vaccines, but everybody's moving there. The other thing about these things is they have immunization planners. This can be really helpful for people who are immunized off schedule. So if you have a child that has moved from another country and the vaccines are not according to the schedule and not necessarily in the combination that we expect, then you can enter the vaccines they've had. And of course, it doesn't supersede clinical judgment, but in a complex immunization schedule, it actually gives you a schedule to follow for these children. So this can be very helpful. And again, as I mentioned, it supports immunizing by history, which is a gold standard. And increasingly, and I don't know how many of you are on Care Connect outside of your life, outside of your hospital life. Yeah, so increasingly, Care Connect, which is an e-health viewer, is available to more and more community physicians. Right now, we have about 175 community physicians. And the immunization record is available on that, which is a new thing, and we're trying to expand it. I don't know about you, and I'm a bit of a Luddite, but when I was on call during the measles outbreak and I could look at people's immunization records from my couch, I was giddy. I was so happy. Anyway, so I think there's a lot, we can complain about it and about multiple systems. We've actually come a really, really long way. The future is bi-directional communication to all providers so that private practice physicians can also put in their vaccinations. Data transfer to a patient portal is ultimately what we're going to need, and data transfer among health authorities. So again, communications can be a challenge. One of our challenges remains right now actually is adult vaccination by pharmacists. So that's not or in fact, any vaccination by pharmacists, they don't tend to make it to our immunization records. And of course, we don't want to create any systems where clinicians are expected to copy a piece of health information from one system to another. That's got us, we cannot keep planning for that. We need to move with the times and come up with systems that where the actual delivery of the vaccine also records it in a system that will be available via a portal to both patients and providers. So with respect to vaccine supply, I would say that multiple formulations for things like influenza can be a real challenge for physicians in the community. And in my personal opinion, it creates some unnecessarily rhetoric around influenza vaccine. It tends to give people the impression that we're changing our minds all the time. But the biggest, there's not a lot I can do about that, but cold chain is another one. I would say that with a variety of providers, not all of them have the infrastructure to have a vaccine fridge in their offices. Cold chain can actually be a bit of an issue. So what is cold chain? Well, cold chain is really the maintenance of the right temperature for a vaccine throughout its transport from the manufacturer to the health unit to the vaccine provider to the person. And it really is a shared task from the time they leave the manufacturer to the time the vaccine is given. And keeping vaccines at approximately 2 to 8 degrees is what cold chain is. And we've done some survey on how we're doing, and about just in physicians' offices, and about 72% use a bar fridge, which is not a great idea. Only 61, pardon?
I don't have vaccines in my office.
Okay.
It's okay.
Okay. You have friends. 70% bar fridge. Only about 60% have even some have a min-max thermometer. 12% monitor daily. Use temperature logs. 55% have non-medicinal items in the fridge. That's known as lunch. Most people notice sort of the vaccines in the center of the fridge, and they tend to put short-dated vaccines in the front, and then return expired vaccines to public health. So I think cold chain management is something that we should pay attention to. The important things are really daily monitoring, being aware that freezing inactivated vaccines will make them ineffective. Most vaccines can't tolerate temperatures above 8 degrees. So if there is a cold chain break, do call public health to talk to us about what to do. We can save some of the vaccine. It's so basic and boring that that to some extent I'm thinking, why am I even talking about it? But it's so basic and boring that I think a lot of the times we forget about it. It is a valuable commodity, and if the vaccine is ineffective, not only did the child potentially not get protected, but they won't know that they're not protected. And I think that's probably the key issue. So those are some of the challenges. And I'm going to talk a little bit about the opportunities and what we, pardon? Never waste a good crisis. I think it's attributed to Churchill, but everything is attributed to Churchill. So I don't know if he actually said that. So a little bit about increasing vaccine coverage, and the percentage of people who are completely not immunizing is hard to assess, but we did one, when we were looking at our HPV vaccination rates, we actually looked in grade 6 and 9, but the proportion of people in various parts of our health authority, don't worry about the lower part, the Vancouver Coastal Health, and then our health service delivery areas. And what are the proportion of children in grade 6 and 9 who are completely unimmunized? And for us, that's an indication of people who have a true philosophical objection to the concept of immunization. And coastal rural is higher, but by and large, it's about 2% in our larger areas. So now the higher bars in this case are the proportion of kids who are not immunized for HPV, which is probably HPV outpaces other vaccines that people choose not to take up by quite a bit. So I like to think of the gap between the red bars and the blue bars as the opportunity. That's because those are individuals who have accepted some vaccines, may have had a reason. It may be convenience, it may be misinformation, it may be some reason they didn't get all of their vaccines. But I think those are the individuals, and our data show us that those are the individuals for whom we have some real opportunities. So the first and foremost, you know this, I don't need to, I, the public health person, don't need to tell you this, that your recommendation as a healthcare provider is absolutely key. So when you look at something like immunization during pregnancy, which is one of the tougher ones to get your head around, if an obstetric care provider recommends and offers influenza vaccine, patients are 5 to 50 times as likely to accept that vaccine, depending on the study. And 88% of parents follow physicians' recommendations about vaccines. So although although there's a lot on the internet, what you say, and I would conjecture that I have no data on this, what you say as a trusted ongoing healthcare provider as opposed to what I say as a public health person is much more important, because you're the person with whom they have a relationship. Immunization education has some effect, but it's a lot of work. And this is just a little bit of data of what we did in some small elementary schools where we had an opportunity to do some education to parents and families in 2016, pre and post, and we have found that we have had a substantial increase in vaccination rates in those communities. It's almost impossible to do that at a population level. So in other words, the education helped in a particularly non-immunizing community. I cannot expand that either. I cannot extrapolate those data to the population level. We also cannot assume we don't have the capacity to do this in every school. There is some education that's being provided. I don't know if you're aware of it, the Kids Boost Immunity, which is going into schools. And we don't yet know what the uptake of that will be, but I think it's a really innovative idea, and hope that it'll be that is coming from British Columbia, and we're hopeful for that. Another way to improve immunization rates is simplifying the schedule. And the reason I'm showing you this data is just to look between 2013 and 2014, and you'll see a jump in all of our areas for HPV vaccination. And what do you think that was? We went from 2 doses to 3. From 3 doses to 2 doses.
You simplified the vaccine schedule?
Yeah, I will do that as soon as I go home. That's nice. But we went from 3 doses to 2 doses. So it's actually quite difficult to fit 3 doses into a school, to have enough humans to go into a school 3 times. So that was an immediate, both a statistical jump, but simply it just meant that you didn't have those people waiting for their 3rd dose. I think another really important thing, and I'm going to toot our own horn for a second, is local data to support local planning. There's a little, if you go to the Vancouver Coastal Health website and look for immunization coverage, we actually give you data on each school's immunization rates. And again, this is the records. This is what we have records of. Our 2-year-old immunization rate based on a survey, as well as school immunization rates at a population level. What is really great about being able to do this, it's actually been taken up by the public. They're interested in this. They look at this. It makes news stories. But also that we actually change what we do based on the school. So in other words, we're actually targeting our efforts to the schools where we have an issue. Vaccination opportunities in school make a really big difference. Vancouver Coastal Health, so my region, if you look at the bottom graph and you look at its HPV vaccination rates compared to other health authorities, has a notable higher HPV vaccination rate. And that is, we think that is related to one and only one thing, which is that we go back into the schools and we re-offer the vaccine in grade 9. So in other words, we offer it again. The other thing, we've done a pilot. We don't necessarily have the capacity to continue to do this, but we re-offered HPV vaccine in grade 12, and we reached another 12% of the cohort. If we actually managed to find all grade 12 students, we could have gone up as high as 86%. Hard to find grade 12 students. And what was interesting, of course, is that 3 of 4 interested students were new enrollments since grade 9. So back a little bit to local data to do local planning. This is in a region where we get a lot of new students coming to Canada. This may not apply somewhere else, but being able to do something that applies to your situation is really important. I would also like to just take a moment to talk about those grade 12 students when we talk about opportunities. And I'm going to now put on my communicable disease control hat, which is what I've did for many, many years. When I look at who gets vaccine preventable diseases, there are the people who choose not to get immunized. That's absolutely much, much higher risk. But then we have a lot of young adults who, for some reason, are not quite up to date. So there's some changing epidemiology of diseases. So for example, and subsequent changing recommendations. So one of the things, for example, that happened with young adults is that we used to offer 1 MMR, then we offered 2 MMRs, and there's a whole cohort out there with 1 MMR. So that was, and then we had a number of mumps outbreaks in Whistler, for example, because we had the perfect storm. We had a bunch of young adults with only 1 dose who live in congregate settings in Whistler with a disease that transmitted through saliva. So we know what happened there. So we have we had a couple of outbreaks about that, based on that. Many young adults were not immunized in Canada, and many have missed immunizations. Again, keeping in mind that if you've arrived in Canada after grade 9, there is no active opportunity for you to be immunized again. There isn't a scheduled opportunity for you to be immunized again. I think that's actually important for us to keep in mind if you see someone who's arrived in grade 10 or grade 11, because it's not going to happen. And the other thing that's very interesting is while their parents may not have chosen to protect them, they may wish to protect themselves. So I think that's really, I wrote that wrong. So of course, as young adults get a little bit older, they can give consent, and given the opportunity, they'll get vaccinated. So I just want to, when I would recommend, interpret I had all my shots with caution. That's a really important thing to do. And I do think that an opportunity that physicians have that public health doesn't is that time when young people leave school for the first time, because there will not be another. That's the last time there will be an active opportunity where mom took you as a baby, the nurses went into the school when you were a school-age child, and I think for us to be aware that that's it for active. After that, it's opportunistic. So I think it's for me would be a good clinical reminder if you happen to have an 18-year-old in your office, not that they go to the office very often. Outbreaks, as I mentioned, it's important not to, how am I doing? How am I doing for time? Oh, okay, I'm going to be done. I'm doing great. Outbreaks are actually really important. As I mentioned, you don't want to miss don't want to waste a good crisis. In the couple of weeks of a very small outbreak, because it really was a very small outbreak, there were more than 1,100 news stories about the measles outbreak. It was actually a very small outbreak. Pardon?
It's okay.
It's okay. A couple of things that were interesting though. We gave nearly 2,000 extra doses given by public health nurses during those couple of weeks. We gave nearly 14,000 doses to community immunizers during that time. And again, a little bit, because I think other people are going to talk about vaccine hesitancy, which is, I think, a really important thing to unpack. I'm sure you all know WHO named it as one of the top 10 public health threats of 2019, vaccine hesitancy. When we went into the school, we actually had to exclude kids from school. So we had to exclude them because we had, if you're exposed to measles and you're not immunized, you're actually excluded from school to prevent ongoing transmission. And we had to exclude 29 children. 23 had actually chosen not to be immunized. I do think it's important that 14 were immunized for the first time when there was a consequence of not immunizing. And that consequence is I can give you a definite date to return to school if you get immunized now. I cannot give you a definite date if you don't get immunized because there may be ongoing transmission. So I just think, to me, that's an indication of the strength of the conviction. And I think one of the things that we all believe is that the absence of seeing a consequence of not immunizing is probably contributing to vaccine hesitancy. And we certainly have some evidence of that in our outbreak. And a little bit about the outbreak, I think one of the things we learned from this outbreak is that there were some polls, 78% of Canadians supported mandatory immunization for school entry. There was a real change in the rhetoric that those of us who were giving all those interviews experienced. There was a real change in the narrative around vaccination with this measles outbreak. There was definitely a different public response, and the public discourse was about the right of a parent to send their child to school and be assured that they will be safe from preventable harm. So I think that was a really, the questions changed, the interviews changed. I've got 5 minutes, I'm almost at that. So And you may have heard that there's some policy changes impending. One is the Ministry of Health is proposing to require vaccination records for school entry. We in Vancouver Coastal Health actually support at least discussing not just vaccine records, but mandatory vaccines for immunization. There are a number of policy reasons for that. One is that basically children whose parents chose not to immunize their children caused the last 3 measles outbreaks in the Lower Mainland. So, but also that we know that mandatory immunization rates for school entry increases immunization rates. It's a complex policy debate that we're not going to have in the last 5 minutes. But I do think it's important that if we're going to introduce something that is that labor intensive, we have a meaningful policy debate, and I hope that physicians, family physicians and pediatricians would be part of that. And I did want to just give you some resources. Dr. Bettinger mentioned the BCCDC website, and they did a really, really good job on that link, but with everything except the length of the link. It's actually not easy to find, so I put that on your on there for you, because it actually really is a single spot source for immunization in British Columbia. It has the schedules, it has the adverse vaccine events, it has it has access to a whole bunch of tools. So I would recommend that, and thank you for thank you for your attention.
Time for one question?
Sorry, I went over.
So why aren't we like Australia?
Yes.
I mean, I think, why are we allowing, I take a much harder line, look at smoking, look at seat belts. We don't allow people to have philosophical differences about that. I don't know, is this unique to Canadians that we're so inclusive? We really don't want to offend people. We don't want to be, in the UK they talk about a nanny state, telling people what to do. But this is so overwhelmingly a good thing. Why do we have so much difficulty, and we have so much problems? We put all these structures in to allow people to have the option. I mean, as a public health physician, this is probably a debate you guys have all the time.
Well,
That was excellent. We can have a 5-minute break now, stretch, go to the washroom,
Still wine
etc.
next door, if anybody wants.
By the way, please come by the room next door where there is to-go food. For your next 6 or 7 dinners.
Okay.
I'm happy to welcome back Dr. Julie Bettinger, who is now going to talk to us about vaccine hesitancy and perspective.
Thanks. I think we've already touched on a lot of this, so my talk may end up being somewhat repetitive, but we'll go for it anyways. I'm not going to go through the disclosures again. So the objectives of this talk are really to define vaccine hesitancy, so you have sort of a working definition of what at least I'm talking about when I refer to it. I'm going to present some of the determinants of vaccine hesitancy that we know for Canada, and I'll review some strategies to address vaccine hesitancy. So we've already talked a lot about this. Everybody knows it's a problem. You've all probably seen some of these pictures, some of these headlines. This was a survey done by Ecos Research in 2011, and what I find interesting about this survey is it's asking to what extent do you agree with the following statements? Concerned that newer vaccines are not as safe as older vaccines. 51% agreed with this, but they're concerned about that. They're concerned about the safety of vaccines now more than they were 5 years ago, 43%. Adverse reaction to vaccines don't get enough attention in the media, 40%. So, and then you can see going down here, some of the other 16% don't think vaccines are safe. At least that one's, you know, a small proportion. But it's a little bit worrying when you have sort of over half of at least the Canadians that responded to this survey being concerned about our new vaccines. Reka very nicely presented, you know, the number of new vaccines that we've had in the last, you know, 10 or so years. And there has been quite an increase, but it's really worrying to me as someone who works in vaccines that we have so many people feeling that, you know, we shouldn't be using these vaccines. There's something wrong with them. So for this talk, and often when you hear vaccine hesitancy, what people are referring to is a delay in acceptance or a refusal of vaccine despite the availability of vaccine services. So I think this is really important to talk about. We're not talking about people who are not vaccinated because of access issues. These are people who have actually had the opportunity to vaccinate. They could get their child, they weren't working 2 jobs, they could get their child to a clinic when it was open, and they chose not to. So oftentimes we lump everybody together, people who are unvaccinated as being vaccine hesitant, and that's not always the case. In fact, frequently there are access issues even in Canada as to why people are not vaccinated. So just for the purpose of this talk, I'm actually talking about the people who have actually made a conscious choice not to do it. So I think the other really important thing is that this is a very complex issue. If there was one solution, we would have already fixed it. It's very context specific, and everyone's always looking for sort of who is a vaccine hesitant person, but it depends. It varies across time, place, and the vaccine. I'm sure that you all know people who have said, oh yes, my child is completely up to date. And you ask them, well, what about the flu vaccine? Oh, we don't do that, right? So I think we probably have colleagues who actually say that. So you know yourselves firsthand that it does depend on particularly the vaccine we're talking about. It can be influenced by factors such as complacency, convenience, and confidence. So I think something that people don't always appreciate or realize is that vaccine hesitancy has been around since the first vaccine. It's as old as Jenner's since he first scraped cowpox blisters and inoculated people with it. This cartoon that I have here is from 1802, and if you can't see it in the back, what it's showing is people developing bovine features from Jenner's vaccine. So it's nothing new. We've been dealing with it for hundreds of years, perhaps not dealing with it well, but it has definitely been around. And in fact, there's a great talk, if you like podcasts, on the Sunday edition that was given by one of my colleagues in Ontario, Heather McDougall, if you want to look for it. And she's a historian who has looked into sort of the history of vaccine hesitancy in Canada, and it's worth a listen if you like that type of thing. I just kind of mentioned that as an aside, but
Which website?
The Sunday edition, the CB, I can send it, yeah. So anyway, that was not at all part of my talk, but good to know. In case you like, I'm kind of a history buff, so in case you like that sort of thing around health, it's an interesting listen. But vaccine refusal, as we know, and in fact, I should probably have just changed this slide to the recent outbreak in Vancouver, but yes, it's associated with outbreaks. It's also associated with deaths. I think sometimes we forget this, or certainly not all parents are aware of this, but I've just listed some here. The most recent 8 whooping coughs in 2017 in both US and Canada. So it affects many vaccine programs. We know that. We've seen that firsthand. So the WHO SAGE Working Group on Vaccine Hesitancy has come up with sort of this continuum of vaccine hesitance or vaccine acceptance. And the way it works, it's kind of our typical pyramid here, or the epidemiologic pyramid. I'm an epidemiologist, so I like these sorts of drawings. But at the bottom here, the majority of people in the green have no doubts or concerns, and this is where most people sit. We have some people sort of in this lighter green area with minor doubts, and then some with many doubts and concerns. But in spite of sort of where they are, they're at least all accepting vaccines. So it may be difficult to know when someone's fully vaccinated if they're down here with absolutely 0 doubts or concerns, or maybe up here with many doubts and concerns. Then we have sort of this yellow area where they're late or selective vaccinators, and I'm sure you've probably encountered people in this group where maybe they skip the MMR, they don't do the flu vaccine. We all know people in that category. And then this very top piece are people who refuse everything. They've never received any vaccine. So the acceptors down here are sort of, they consider, if you want to sort of try to generalize, they consider vaccines important. They consider vaccines safe. They trust their healthcare provider, which is a really important point. And they're influenced by the social norm. But for them, the social norm is that people vaccinate. So all of their friends and family and all of their sort of people they speak to are vaccinating. And that's part of their influence. So the hesitant are much more focused towards vaccine risk. And this is, for this group, complacency may actually play a role in their hesitancy. I mentioned that as one of the factors. So they have a very low perceived benefits of vaccination. Therefore, if there's not much benefit, why bother get vaccinated? I think it was 14 people that Reka mentioned who suddenly decided to get vaccinated. Well, suddenly being complacent just wasn't so attractive anymore, right? I mean, that's a very good example, actually, of some of the people that fall into that category, right? But I think what's important is they can move up and down the continuum due to various influences, one being a measles outbreak that, okay, now I'm going to get the vaccine, but just as easily it could be, an adverse event or some scary story in the media, and then they decide, oh, well, maybe I'm not going to get vaccinated. So they can go either way on it. We think with most of our estimates, and you've already seen some figures on this, that about 80% of people accept all vaccines. They're somewhere around here. They may have some doubts, they might have many doubts, but they still get vaccinated. This group in the yellow, the selective or late vaccinators, these are the people who really have significant doubts on the safety and the necessity of vaccines. They're actively seeking information. They have very conflicted feelings on whom to trust, and they're influenced by social networks, but their social network may not be pro-vaccine. And so they may be influenced by friends who are not vaccinating or family who are ardent anti-vaxxers. And then we've got about 2 to 3% of the population, and Reka backed that up with her statistics from Vancouver Coastal, who are outright refusers. They're very strong-willed and committed against vaccines. They oftentimes will have a natural approach to health, and sometimes they have religious or moral considerations that are driving sort of their resistance or their refusal. So this was a survey, again, another echo survey that was this one done in 2017, and I put this in here because this sort of breakdown from WHO I think is kind of interesting in terms of the percentages. But what we actually saw with the Canadian, with again another population survey of Canadians, is that the percentages actually broke out fairly similarly to what we thought in this pyramid. So about 48% had no doubts or concerns, 34% had minor, 6% had many, but they got vaccinated anyways. When you looked at the group up here, which we estimated to be, around 15 to 20%, in this pyramid, the people who refused or delayed or refused all, it came out to be about 12% who were the very hesitant and who were not immunizing. So it's, the numbers are looking better when you do a population survey in Canada, which I find encouraging, but I think it's pretty accurate to sort of say people are probably somewhere on here. You could potentially do this poll at another time, maybe after a scary event, and those categories might look slightly different. So who's hesitant? So I think when you talk about vaccine hesitancy, for many of us, this is probably the image that pops into mind, right? The wealthy white Malibu mother who breastfeeds until her child's 5 years of age, homeschools, is obviously not going to vaccinate. But while this may describe some vaccine hesitant parents, I think really it doesn't do it justice. Anybody can be vaccine hesitant, and in a lot of the research I do, we actually talk to vaccine hesitant parents and parents who refuse vaccines, and it's not one group, and I would really caution you to just sort of box people into this category. I'm actually quite frustrated even with my own colleagues who do this research, who sort of think everybody's wealthy and white who are hesitating, and that's really not how it is. And so it's as diverse as all of us in this room, and there are different reasons for each individual. The woman from the religious community, her reason for vaccine hesitancy may look different than the immigrant mother's reason for vaccine hesitancy, but they're vaccine hesitant, and so we don't do ourselves any we're not going to address this problem if we keep trying to put people into one box. And again, it changes over time and it changes over vaccine. So you may have patients who are very vaccine confident, but they get pregnant. And suddenly they're not as confident and they're more worried and they don't want to do any harm. And so again, I think that, well, actually as pediatricians, hopefully you don't have any patients who get pregnant. I just thought of that, but anyway, you know the point I'm trying to make. It does change with time and it does change with circumstance. And women who have been confident about vaccination suddenly may not be in pregnancy when they're having to decide whether a flu vaccine is a good idea. So I already touched briefly on some of this, I think, but there's sort of three main determinants of vaccine hesitancy: complacency, which I discussed a little bit, convenience, and confidence. And I'm going to mostly focus on the confidence piece because I think as healthcare providers, that's the area where you can really have an effect. Complacency is more of an individual. That's the recipients. That's the patients. That's on the patient's side, and it is a bit more difficult to affect as an individual healthcare provider. But for complacency, that's when someone sort of perceives the risks of vaccine-preventable disease as low, vaccination isn't deemed as necessary, preventive action, and there's other life or health responsibilities that they put in higher priority. I think something like the outbreak that Rekha gave is a great example of how you affect complacency. That's a little bit hard to do, as an individual healthcare provider, but boy, when we have those sorts of things occurring, it's great to take advantage of them. Convenience is another one, and this is more of a health system issue, I think. Again, a bit difficult to affect as an individual healthcare provider. But things that come into this are willingness to pay. When we have some vaccines that are not publicly funded, oftentimes parents interpret that as they're not needed. And therefore not important. And that also gets into equity and access and some of those other issues. But willingness to pay, if someone's a bit hesitant, they might be even less likely to want to fork over money for a vaccine that they don't really think is necessary. Also, the ability to understand, both in terms of language with our immigrant communities as well as health literacy with everybody, can be an important barrier. And then the appeal of the immunization services. We talk to a lot of parents who just don't feel safe sometimes in where they have to seek care. And so, I think, as we've already said more than once, a trusting relationship in a place where you feel safe is going to be really key for people having confidence. And so when people are confident, they're quite able to make these decisions. But when they don't have confidence, then they really have a lack of trust in both vaccines, in the delivery system, in the healthcare provider who's making that recommendation, in policymakers who decide on which vaccines they need and don't need. And people in this group with somewhat shaky confidence, when they have vocal vaccine deniers, whether they're their friends or even just in the media or on the internet, they can really have a big influence. So in terms of just some sort of, again, please don't put people in a box with this, but what we see from studies in Canada in terms of factors that will influence vaccine acceptance. So some kind of demographic characteristics are older maternal age, higher income, increased education, presence of medical comorbidities, prenatal care by a family doctor. That's from talking to a lot of pregnant women or parents with young children. Some of that data comes from. And clear information provided by a trusted healthcare provider, but the number one thing is a recommendation by that trusted healthcare provider. So those of you in the room here tonight and listening online, you can really make a difference here. That is the number one reason. A clear, unambiguous recommendation from a healthcare provider they trust, it has a huge impact. So some determinants of vaccine rejection or hesitancy. So younger maternal age, low income, and I have to kind of wonder sometimes with the income ones if those aren't potentially confounded with access issues, because some of the studies haven't always differentiated very well. But fewer prenatal care visits before 32 weeks gestation, prenatal care by an OBGYN, interestingly enough. I think that's because oftentimes they haven't in the past viewed that as part of their scope of practice. Hopefully that's changing because we have a lot of prenatal vaccines already that have been approved. We've got 2 now, and there's more that will likely be approved. Safety concerns, lack of knowledge about risk, and the number one is a past negative experience with a healthcare provider, medical system, or vaccines. What we hear often we've done some studies with parents who've changed their minds about vaccinating. Either they were and they stopped, or they weren't and they started. And for that group who were and they stopped, one of the number one reasons they stopped was that they had a negative experience with healthcare, and it didn't oftentimes had nothing to do with vaccination. Sometimes they'd had an older child with a chronic medical condition that they couldn't figure out, and they were just frustrated. They weren't getting direction they needed, and they stopped. They didn't trust. They didn't have anybody they could trust in the healthcare system anymore, and they walked away from it. So those are somewhat heartbreaking stories because you kind of feel like, man, if you can just sort of like on a one-on-one basis bring that person back in, you can change their mind. And in fact, on the positive side, the parents who did have their mind changed, it was very frequently because they had a healthcare provider who they trusted, who made that recommendation, and who built a trusting relationship with them. I already gave all the information on this slide. So past experience with health and vaccination, again, so past encounters. But I think another important thing that often gets overlooked is there are some people, it's not a lot, I think a lot of studies I've seen estimate maybe 5% of people have real fear of needles and pain. And for them, that's like a non-starter when you start talking about vaccination. The thing is, though, we have all sorts of techniques we can use now to maybe not get around to needle phobia so much, although there are some great distraction techniques that can be used, at least with kids. But certainly for pain, you can numb the area. There's different things you can do to sort of overcome that issue that we should be trying to use for that very small group of people who have those types of concerns. And then the other point is, if someone has had an adverse event following immunization, either real or perceived, and it doesn't matter, because if they think it's real, that's what's important, then they may have real concerns about getting another vaccine. Again, I already talked about trust in the health system and healthcare providers. I'll move on. But so this was, again, that poll from 2017 asking where did you look for information, or who did you talk with about childhood vaccines? And you can see 84% spoke with their healthcare provider. So yeah, 65% looked on the internet.
I think the most part is really encouraging, 25%.
Yeah, books, yeah, that's true. But when asked how much trust they put in these sources, so again, 91% in healthcare professionals. So even though you may not feel appreciated some days, just remember that. And the other thing we find from talking to parents, particularly vaccine hesitant parents, they can tell when a healthcare provider is even a wee bit hesitant, right? So when you talk about making like a very solid recommendation, anything of like, well, any sort of wavering on it, they pick up on immediately. So just be conscious of sort of how you're doing this recommendation. Okay, so this was a study that looked at parents who had planned to delay or not get a vaccine for their child. So these were that group of sort of the yellow and the reds in the pyramid. And the thing that had the biggest impact on them deciding to immunize was information or assurances from a healthcare provider. So over 40% of that group who was saying, I'm not going to do this, they were able to have their minds changed. So I'd like to see 100%, but hey, I'll take whatever we can get with this, right? Okay, so I'm not going to spend too much time on sort of approaches, but there are different ways that you can communicate. And one is sort of this hardline approach. And again, it's been interesting because I've had this conversation several times over the last few days about, well, should we just insist that they get all of the vaccines in the recommended schedule in the order that it's supposed to be? Or is it okay if I kind of, bring them along more slowly if that's what they're more comfortable with? Two different approaches. I'll kind of go through some of the evidence. You guys can decide what suits you best. But the hardline approach would be sort of emphasizing the irresponsibility of vaccine refusal, refusing to treat non-vaccinating families, and enforcing mandatory vaccination. So if you are leaning towards the hardline approach, it's probably good to know that fewer than 35% of people in British Columbia agreed with doctors dismissing patients for non-vaccination. So this is not something that gets a lot of support at a population level. There's probably going to be a lot of backlash to this. There may even be legal ramifications. I don't know. I would recommend you look into it before you go down that road. But I think it's important to remember that most vaccine hesitant parents are not uneducated, poor, or unconcerned about health. That's not why they're not immunizing. So there are some techniques that may help. Again, remember, your recommendation is number one. But I think along with that, and it's not just a recommendation from a healthcare provider, it's a recommendation from a trusted healthcare provider. So it's that trusted relationship that's really important. And maintaining that trust is important. I think if you dismiss someone from their practice, you've probably broken that trust relationship. It's also important to use effective patient discussion techniques, clear language. What I've found interesting in a lot of that group of parents we talked to who changed their mind, who weren't immunizing and decided to, it's quite interesting because for a lot of them, when they understood the role of herd immunity, that's what convinced them to start vaccinating. Which is really interesting, it's not just about my child. And we have parents who don't vaccinate who say, well, I don't understand why it matters what I do with my kid. You can vaccinate your child. Why do I need to vaccinate my child? So there's clearly, we get it. We understand herd immunity, but most people don't. And they don't understand that it's kind of this social contract that we have. And oftentimes when they understand that, they may not vaccinate right away, but it gives them something else to think about. A little bit more, my decision is impacting other people. Am I still okay with that? So that may be something to just make sure if you have someone who's resistant, that they know that. And then again, pain. I already talked about pain. So what discussion techniques work well? So there's a lot. There's a mountain of evidence, or not, a mountain of research, let's say. The problem is there's not a lot of clear guidance. And I think, there's a real gap in terms of, what technique works best? I'm not gonna be able to tell you that. And I think part of the problem is because all of us communicate differently. So when you're trying to evaluate this in a study, you have the person delivering the information and you have the person receiving the information. And they each are bringing different things to that table. And so, what might work well in one study might not translate well in another study or another setting because the communicator changes and the recipient of the communication changes. And I think that you all probably at this point have figured out ways to communicate with your patients that work for you. And I think Jane's going to talk more about this, I'm hoping. But just in terms of the evidence, there's not a lot. I'm not going to be able to say this is the way you have to do it. This was an interesting study here that was looking at sort of presumptive or participatory communication. So the presumptive would be, so we'll do this in 3 shots. Is that okay? Just assuming that they're going to do it. Versus the participatory, which is, what do you want to do about shots, right? So more of the motivational interviewing. What do you think about this? So if you look at the results from this study, there were 26% that still didn't get vaccinated with the presumptive approach, but 83% who didn't get vaccinated with the participatory approach. But, that said, that, that might indicate that directive versus participatory, that the shared decision-making might not be appropriate with immunization. On the flip side, I'm involved with a current randomized controlled trial, which is examining motivational interviewing on maternity wards. And this was initially started in Quebec, and they found it so successful that they've basically implemented this as part of their public health program. And so now they're doing this in all of their maternity wards. I'm not so sure we're going to see the same, the study results aren't in yet, so I'm speculating, but just knowing differences between the way maternity care is delivered in BC compared to Quebec, I don't know that we'll see the same effect. And it may have nothing to do with the discussion technique, but everything to do with the fact that in BC, most new moms are discharged within 24 hours, whereas in Quebec, they're in the hospital for 72 hours or longer. So, that right there might, again, context, it's all context, right? And when we talk discussion techniques, those same things apply. So, I'm happy to come back and present those results when they're available and have more conversations about motivational interviewing. But I do think the jury is still out, and I'm not convinced we're ever going to be able to say this is the way to do it, because I don't actually think there's one way. So what you can do, and you probably already know this, listen to the person in front of you. Make no assumptions about that person and where they are on that hesitancy spectrum. Identify their questions and concerns. You will need to have extra attention and provide more information to hesitant parents, whether or not they vaccinate. And particularly for a parent who has had an AFI or some sort of chronic health condition or something that has caused them to really mistrust the care they've received in the past. If you're the person they're coming to as someone that they're trying to trust, take advantage of that and work with them, because they may not reach out again, or they may not reach out again for a very long time. Tailor your advice. You probably already know that. And again, recognize that 91% of you are the trusted source for 91% of the people in that poll, you're the trusted source. But when you're talking with vaccine hesitant parents, they're going to want to verify what you're saying. So you're going to tell them something, and they're probably going to go away, and they're going to go look at their sources, and they may come back to you and talk to you about it again. Go away, come back again. That sort of triangulation of information sources is very common among very sort of hesitant parents, because they're seeking information, they're unsure what to do, and this is how they process it. So don't be offended by that. Just expect it. Okay, if you didn't get this from my talk, you are one of the most trusted sources of information for your patients, and your recommendation can change behavior and result in healthier children and adults. So, and all parents want to do what's best for their child, and it's a continuum. So I do want to acknowledge some folks that have that I work with in vaccine hesitancy. So Ev Dubé, Noni McDonald, and Devin Grayson, Clara Rubenkamp. So they've all sort of provided information and slides that went into this talk. I have resources as well. So yeah, some of the same ones that Reka had. So yeah, you guys, I think the slides are available after this, and happy to, and I also think I have my references here if you really want more information. So knock yourself out. So.
Very good. We always have time for a question. Any questions? Paul.
One of the things that the most frustrating things I find is the number of parents, educated, whatever, who still feel their child has to be completely, perfectly well before they get the vaccines. They've got asthma, they're coughing, and he's still coughing. He had a cold 2 weeks ago. How does one get over that? I mean, I find that so frustrating, and I run to that regularly.
Well, yeah, and
I have an answer.
Yeah.
David Trifley taught me what to say. And that is, if you get all your vaccines for your entire life on one day, you would use up 0.1% of your immune system, which will all be generated back the same day. And the second thing is, the only reason not to get your vaccines when you're a little ill is if you're in intensive care. Because when you change that occurs, you don't know what's caused what. But if it's just a general cold.
I
Well, I
like
have
that
no
one.
trouble telling what to do. I mean, I'd say,
Yeah.
I think if you've got an active infection associated with fever on that day, don't get your vaccine. That's
You're
what I
very
would
right
say.
though, Paul, because a lot of kids don't get their 18-month shots because they've got the sniffles. You know,
Yeah.
and it's a lot of kids aren't, they're under-immunized, right? Because of that lack of opportunity or the lost opportunities.
Can I ask one question? I love looking on the CDC website, looking at all the statistics and the maps and things. I'm kind of a geek. And Kootenai boundary, for obvious reasons, the immunization rates are low. Northeast BC, the immunization rate, especially HPV, I think like HPV is 50 or 54%. Is that hesitancy or is that a lack of access, difficulty accessing? Do either?
Well, so I think, so that's a great question, actually. And I'm glad you asked that, because I think when you look at coverage rates, that's the question you should be asking, because you can't assume that what would it be, 50% who aren't immunized, it's because they're hesitant. There may well and likely are access issues there. The child may have been sick the day that they came to do the school clinic. When you get out of the Lower Mainland, there are not that many other community immunizers outside of public health. So, and I'm not knocking public health at all, but I think there are real access issues, particularly in our more rural and remote areas, and that often gets conflated with hesitancy. I think we could do a lot towards addressing some of the access barriers. That would bring our rates up considerably, and then you would really only be dealing with a very small proportion who are truly hesitant. Yeah. I don't know if that answered your question, but I don't actually know.
Either. Yeah.
I don't actually know. It could be either, but it's definitely not all. I would put money on it that it's not all hesitancy.
Our next speaker.
One comment,
Thank you. Oh, another
problem
question,
that-
sorry.
Sorry, just is parents who come in and do research, and I know for you people, that's, you know what research is, and it's because they spent all evening on the internet.
Yeah.
And usually when I say that, it's good that you're looking up, and I acknowledge that they're doing the best for it. And I usually say, well, tell me what web pages you've gone to. And they usually say, Dr. Google or something, and they usually can't come up with the web pages that they've gone to. And also, as we all know about social media and how configured it is depending on your interests, you all know the algorithms in it, and you will get this sort of stuff. So I usually do combat that with the Caring for Kids website.
Yes.
Which today I got little cards for, which actually is quite good. You can get from the CPS for free. And say, well, here's a really good evidence-based website that you can go to, because I think it's really important for you to look stuff up. But the death of authority is really the phenomenon. And that's why I think the young don't vaccinate to some extent and don't do a lot of these things, because they can look up WebMD, they can look up Wikipedia, and they're an instant diplomat, and they look up WebMD and they're an instant doctor. So it's trying to fight fire with fire, I think.
Yeah, no, I agree. And that's why when I talk on vaccine hesitancy, I like to give websites both for physicians to use and for their patients to use, because the studies have definitely shown that hesitancy increases when parents are on the internet. So yes, please be providing them with fact-based websites that they can look at, in addition to wherever else they happen to end up, right? There's a lot of junk out there.
Thank you very much. Our next speaker, a partner in crime here, Dr. Jane Finley. Dr. Finley obtained her medical degree from University of Alberta, did pediatric residency at Stanford, and a fellowship in pediatric infectious diseases here at BCCH. She's a community-based general pediatrician, but she also works at BCCH at the New Family Immunization Clinic, and in her own practice in Vancouver, she's a frontline vaccinator. Dr. Finley's on the Children's and Women's Infection Control Committee and is our BCPS representative to the BC Center for Disease Control Immunization Committee, and helped to plan this. And she is also a media star.
Oh, well, you guys wrote me into that.
And Jane is going to talk to us about counseling the vaccine hesitant parent, and that will lead into our group discussion.
And a lot of my slides are repetition of what's already presented. So I thought I would just tell some stories. Okay. And it will segue right into our panel discussion. So, this is not my presentation.
Panel part.
This is the questions at the end.
Jackie, are you there?
This is someone else's presentation. There's the questions at the end.
Okay, so just tell me what to do.
Oh, just forward out.
Just forward.
Moving?
That's the one after this. Maybe I numbered it wrong.
Yeah, so it's
Okay. It's timing. No. So you want to switch?
Mhm.
the one said Finley.
This one first?
No. This whole presentation is the last presentation. We need the second to last.
Oh, okay.
Okay.
I know. It seems like a long
Okay.
meeting.
So we open it here.
5, vaccine hesitancy.
Okay.
All right.
Sorry about that.
Okay, thanks. All right. So I have received some payment through BCPS for work done through Merck and GSK. So learning objectives. So factor and prevent decision making. So again, number 1, 2, and 3 is the vaccine safe? And is the threat the disease poses, is it important? So how common is it and how severe is the disease? And certainly in 2009, we had the H1N1. It was fabulous, people getting flu vaccine. And I remember Patty Daly saying the best way to get people vaccinated is when with the flu, you list everyone who died. You call it a pandemic. Then you tell everyone to get vaccinated, and then you don't have enough vaccine. and it's somewhat similar with measles, right? But no one's died. It's great. But I guess there's some really, really sick kids in New York, in intensive care, and a lot of children have died in the Philippines, etc. So they're not so worried about effectiveness, though, because most people do feel the vaccines are effective, but they don't feel that it's prevalent enough to be worthy of the side effects. Though they're really sneaky when you look at these sites. They go, more kids get pertussis who are vaccinated than those who don't, right? But then you have to look at the denominator, right? And so they're very, very sneaky. And there's often a kernel of truth in the anti-vaccine sites. And if it's not publicly funded, they want to know how much it costs. So again, there was a really interesting podcast on through the Canadian Medical Journal, and this Dr. Maya Goldberg, she suggests that our population is actually quite educated, and there's only so much we can do, but there's a fundamental persistence of belief, despite overwhelming evidence, in support of vaccine safety and effectiveness. And why? Because there's a distrust of science, the medical system, and government recommendation. We're talking about younger kids. Maybe these young parents feel disenfranchised. They can't afford housing. The job you have for your entire life is gone. So there's a certain feeling of being disenfranchised and not being cut off. And there's huge conspiracy theories, and even there's an Interwest or Insight West survey recently. It was a good 15-20% of people distrust the science, they distrust big pharma, and it's all a giant conspiracy. But on the other hand, when I say, well, maybe the Russians are involved, maybe there's a conspiracy, maybe there's someone that really, really doesn't like children and wants to have population control. I don't really say this all the time. It's come to my mind, right? What if there's some big conspiracy to have population control, right? But no, that's never accepted. It's always like big pharma, is their agenda. And it's a huge leap of faith for, if you're not involved in vaccines, even as a healthcare provider, to accept the science and to give something to a healthy child, right? And there's some thought that maybe that ideally science drives policy, but there's always a bit of a filter, right? And then perhaps maybe we should be a bit more transparent in how this all comes about. So there's certainly a power of celebrity, the downfall of expertise, the media. And here's the wife of the White House communication director says she wants to be childhood diseases, they keep you healthy. She wished her children had measles like she did when she was a girl. And there's this thing out there that if you get measles, you get less cancer. But what it was is that the measles vaccine was being used as a vector for an anti-cancer drug. It's for targeted therapy. So how that gets translated into measles gives you less cancer. And there was at one point that measles gives you less MS, probably because measles is immunosuppressive. The problem is that islands that had huge measles epidemics, they didn't have as much MS, but kids, massive number of children died from measles. But there you go. Okay. So, and certainly this has been attributed to Adolf Hitler or his henchmen, that if you tell a big enough lie and tell it frequently enough, it will be believed. And some parents are more afraid of autism than death. And I've certainly been seeing some of these kids involved in the French school system. One mom, she came in, she is so afraid of MMR for her, like, I don't know, 9-year-old, that she was asking me whether she should go over to the family that had measles and purposely expose her child. She's just so afraid. If you can just imagine, I go, oh no, don't do that, please. I had measles. I was very sick. So, but it's just interesting the persistence of that type of feeling. And then certainly if you look at some of the internet, this Vaccine Choice Canada, it looks very official, right? So you go on it, and here's Jenny's story, SIDS. Our daughter passed away almost 9 years ago from SIDS, but we firmly believe it was from her shots. And there's lots of stories on like that are very, very powerful. And we know that SIDS happens, and a lot happens when children are between 2 months and 18 months of age, right? But the stories are very powerful. Well, I think the media has been pretty helpful recently. Lots and lots of very on side this time with the measles, and it wasn't really that many cases either, but it was pretty cool actually, and it's been interesting how this is this government seems to be on side and planning for the vaccine registry. So the minister, I know, it's going to huge operational issues trying to get. Now you guys are gearing up to going into the schools, right? Yeah, so to give measles vaccine. So we've gone through this before about common concerns: too many shots, too young, natural infection is more natural, vaccine safety. Aluminum's the big issue right now. So, and then you go, okay, well, do you eat commercial bread? I said, yeah, well, that's aluminum's in the baking soda, right? Or to use deodorant? No. What do you use? Rock salt. Well, rock salt, aluminum's in the rock salt, but it's hard to get around that one. And there's some concern that vaccine can cause the disease. Not quite so much anymore, but again, you can say that polio vaccine causes polio, and at one point we were using live polio vaccine, and it did, right? And you can get flu-like symptoms from flu miss. So, again, sometimes there's a kernel of truth to things. So I have gleaned this from Scott Halpern, who actually did I think ID fellowship here years and years ago. And this is an old article, but I think it's very apt. So he says the steps are listen, evaluate, categorize, recognize legitimate concerns, provide context, refute misinformation, provide valid information, educate, make a clear recommendation, but in the end, recognize that it is a parental decision. So when you listen, evaluate, I give vaccine counseling at the family immunization clinic, but also as part of my general pediatric practice. And even if I'm seeing a child for asthma or something else, I always ask about immunizations. And if the parent says the child's not immunized, I say, is that something that you'd like to talk about? And sometimes they'll say yes, and we might not talk about that time, but maybe we'll talk about it another time. Or sometimes they'll say no. And if someone says firmly, no, I maybe bring it up once more, but I'm not going to go down that road. But I do offer it. And it's amazing, sometimes people will come out of the woodwork eventually. Or I work in a clinic where there's naturopaths, and I can honestly say I have most vaccines into most of their children. But it's only through persistence, right? Because they get to know me, we have a relationship. One of them I've gone to counseling for myself. So, I think they just sometimes get so sick of me saying, oh, is today the day for MMR? And finally say, okay, especially the latest the latest kerfuffle. So that's been pretty interesting. So I like to take, even if they come into the immunization clinic, I like to take a bit of a history. I don't launch right into like, why are you here? No, just I kind of get a bit of a background, what's going on with their family, what's going on with their child, does anyone have hepatitis, are they going to daycare? And then I listen to their concerns. They say to validate the concerns, but you don't want to validate what they think is real. So that can be kind of tricky, right? You might want to validate that I understand you might be concerned, but not actually, yeah, you're right. So you can determine what they're standing the risk, and yeah, it's just to understand and try to figure out where they're coming from. And you can generally divide parents into various categories. So I know this may seem a little bit harsh, but the uninformed but educable. So these are people that they don't know that much about vaccines, but they went to their family doctor, and the family doctor says, I don't know, here's the schedule, but they don't get any specific answers to their questions, right? And there's a huge gap there. So why should I let this guy give me my kid shots when he doesn't really know what he's doing? And so they just want some more information. And for the most part, you can, they're happy to get vaccines. And they're really, really happy. Said, oh, finally we get to talk about an expert, and thank you very much. And it's just quite rewarding, actually. And then you've got sort of the misinformed but correctable. And they might have some specific concerns about like thimerosal or MMR and autism or something like that. And you can often get most vaccines into the children. And then you've got the well-read and open-minded. Well, they come in and go, I'm not an anti-vaxxer. I have done my research, right? And then you look at what they've looked at, and okay, so you can kind of go through that. And they'll often accept some vaccines, most vaccines actually. And then you've got the convinced and content. And these are often healthcare workers, a lot of them, like nurses. Man, nurses who say, I don't trust the science. Okay, you work in healthcare, and I don't trust the science. And you have to wonder, where does that come from? You know, and sometimes they usually won't vaccinate their child, except you can plant these little seeds of doubt. And sometimes if it comes down to, oh, my kid's going to be excluded from school, they don't get the MMR. and now I'm getting them, oh, what else do they need to be vaccinated from? It's about pertussis, and okay, they'll do what it needs to take to keep their kid in school. And then they've got the committed and missionary. And they don't come in with their child. They come in with literature for you because they're trying to convince you they feel sorry for us. We're under the influence of the big pharma, and poor you, and here, they're missionary. Like this guy a few years ago, remember they came out with a mandatory flu process? He goes, I would rather die than force my children to be vaccinated. Actually, that guy said that. Amazing, huh? Of course, you could argue about the efficacy of mandatory flu vaccine for healthcare workers, but they don't have it in Toronto, in Ontario anymore, right? So I think it's very good to be honest, and you can actually bring up some of the, if they haven't brought up about the thimerosal or the formaldehyde, you don't have to bring it up, but you can say there's some controversy. You can talk about varicella, and perhaps we'll be maybe seeing a few more cases later on. It's okay. I think you come across as honest. I mean, I could honestly say my children are fully vaccinated, but I didn't give them that experimental herpes vaccine. I didn't trust the science, and so I can get some cred there. I can honestly tell them that I got the shingles vaccine and the Shingrix, and I was quite sick between hours 24 and 40. I can honestly say that my daughter who got the wholesale pertussis vaccine screamed bloody murder for 3 hours. It was tough, but she did get So you can be honest, because it gives you credibility just by saying they're there, everything's fine. It's not honest, and you won't be seen as credible. So I say vaccines are 99.999% safe instead of 1 in a million unsafe. So I have found to declare to compare the natural infection versus the side effects. And I think I got this off maybe Immunize BC, that you're worried with the side effects, you're worried about that helicopter that's going to drop out of the sky on you, rather than being mindful when you cross Broadway about that truck that's just run the red, right? So so you can let parents know what's happened where they programs have fallen down, like Venezuela. There's polio, right? And you can say we live at the crossroads of the world, and though I think it's controversial whether appealing to their better nature for herd immunity really works. But I must admit, I get polio vaccine into most people. It's a benign vaccine. There's no aluminum in it, so why not, right? And so people say, okay, that's fine. And then you can relate compelling stories. So I think if you're too gruesome, this can backfire. But I had a family I saw that gave a child 2-month IMS, and they came in at 6 months and hadn't had any immunizations. Go, oh, was there an issue? Did you go to public health? They go, no, I think they watched Vaxxed. Yeah, I know. And they said, we've done our research and we decided not further to vaccinate. And at that time, I was still doing the wards, and we had a child with Haemophilus influenza type B meningitis. And she had meningitis, she had a stroke and a seizure disorder, and it was so awful. And I must admit, I almost lost it with this family. I got teary and said, please immunize, but they didn't. I think I don't know what they said. Oh, well, that child was up north. It's not going to happen to us, right? This idea of privilege. But I always want kids to get Hib vaccine. So you can relate stories. Yeah, there's a medical resident turned me on to Snopes.com. A lot of it was really cool. You can look up stuff and debunk it. But parents come in with stuff you've never even heard of. Like they were worried about Tween 80, which I guess is an emulsifier that's also used in chemo agents for CNS penetration. So they're saying, okay, then my child's going to get cancer if you use Tween 80, right? Like all this kind of stuff. And you have to remember, it's very hard to unscare people. They have this primacy effect, and they'll look for information that supports their position, right? When even I was so against video games with my kids growing up, I wouldn't have any of them in the house. And then I went to psychiatry, Dr. Black, and he was all about how video games aren't that bad. Well, okay, but when I left, I still didn't really believe him. But he had pretty good evidence. But I don't know. What does he know? He's a psychiatrist, right? Anyway, so provide valid information, and we've got lots of good websites. Sometimes I direct people to PubMed. If they're sophisticated enough. And then one guy complained, well, I don't like PubMed. There's not enough information about adverse vaccine effects. So, well, because there's none, or it's not an issue. Well, no. Then he says, well, it's all, all the research is driven by big pharma, right? So again, that evidence isn't driving policy. So, and the American one, the Vaccine Handbook by Gary Marshall, that has an online app. I'm finding it quite useful. So we can educate about the consequence and to remind them that general good health, being rich, breastfed, eating organic food. Oh, I get that all the time. We eat organic, so my kids are safe. Does not, people in Africa, they're eating organic, right? Does not substantially decrease their risk. And you can often ask, are you immunized yourself? And yes, you're immunized, and you're fine. And don't you want? And sometimes they say, well, okay, then we'll give the core vaccines. We'll give the core vaccines. So okay, I'm supposed to go on. So. Wait and see is dangerous. You often need at least 2 of immunization to have immunity. And yeah. So again, I think it's again being reiterated again and again tonight. So true that our recommendation is number 1 in a trust, in developing the trust. Sometimes you can develop a trusting relationship so quickly, and sometimes it takes so many visits. And I have families that come in and get one vaccine at a time. Like we usually start with Hib, you know, okay. Like it just takes so long. Okay, and it can be really, really frustrating. Some days, I tell you, you see 3-4 families and nobody accepts immunization and you just think, what am I doing, right? And then other days you get vaccines into the people that come and their siblings and they, yes, yeah, I'm doing a really good job. So here's a cartoon. If you connect the measles, it spells out. My parents are idiots, but most of these parents, they're really not idiots. They mean the best for their children. And by establishing a good trusting relationship, we can accept, at least accept some vaccines. And I think in the panel discussion, we'll talk about whether there's a role for prioritizing vaccines. I get this all the time. They'll say to me, okay, Dr. Finley, I'll only let you give my kid 2 shots today. Which 2 are those going to be?
Let's start with that one.
Okay, so I think that's the end of my talk. So.
Because there'll be lots of time for
Lots of
discussion.
time, yeah. Okay.
All right. Yeah.
So we do have some WebEx people. So I'm just going to say this now. If you have any questions or you want to participate, just send your questions or your comments in. But can you put up my case studies for me? Or tell me how to do that?
Are we up here? Are we sitting down? Or what's the?
I think we can just stay, wherever you'd like. I'm assuming this should be like my normal computer, right? But I'm always afraid that I might do something.
That's fine. So we're gonna do the pause.
No, what we're going to do now is the PowerPoint.
This
Yeah,
one.
this one. Yeah. Okay, so I can do it from here, I think.
There you go.
Okay.
Or you can use the.
Yeah.
Okay.
Okay. Okay, here we are. We're starting with case number 5. So at this child's 2-month well baby visit, the parents revealed that they will only allow their child to receive 1 immunization at that visit. They ask you which one vaccine you recommend that their child should receive. How do you respond? And Jackie, just give a wave if you get something in from the WebEx people, the WebExers, not the anti-vaxxers, the WebExers. So how have you responded in your office, and how would you, and have we got anything from public health on that? Because I know my understanding is that they can't separate the one vaccine out. So, yes, thank you. If you, oh, by the way, I forgot to mention that. You should press the white. And then when the red light's on, you're on.
Well, I think my answer would be dependent on the parent, and I would be honest that I would prefer not to give only one vaccine to your child. I would feel uncomfortable leaving not protected for everything that your child can get protected for. However, if that is your choice, I would actually just be honest with what's circulating. So right now, if your child is going to stay in Vancouver, probably the thing I would most worry about is pertussis in a 2-month-old. So I would make it clear that that's not a choice I wish they had, but I would make a recommendation. I would say why.
And would you schedule the appointment for the next vaccine?
Yes.
At that time. Yeah.
I don't know if other people disagree, but.
Yeah, what are other
Can we
thoughts?
separate out the pertussis?
No, I mean,
No.
I can't give a single, I thought it was.
One vaccine? Oh, a single shot now.
Single shot, yeah.
Single shot, I would say pertussis. But because it comes with a whole bunch of other good things.
Other thoughts?
So I'm not a clinician, so I'm not.
But you're a parent,
But
and you do know something about
I'm
vaccines.
basing this on what I know from the impact surveillance, because I see all the kids who die from the vaccine preventable diseases, and my vote would be for pertussis as well at 2 months of age, knowing their risk of death, and actually, it probably even needs to be younger than 2 months of age, really, for pertussis, but. If I was presented with that question, I would do the same thing. But the great thing is, I don't think we have a single pertussis vaccine. So as Rekha said, they're also going to get a whole bunch of other ones with it. And it's still just one shot. So.
Yeah.
Can I ask a question? So if they ask
They say they'll only allow one immunization. Do they usually mean one shot, or do they mean for one disease? I really don't know. What does the question mean?
I find a lot of parents at this age don't want the hepatitis B. And they'll accept PHSA maybe at 2 months, and then you can do the Prevnar at 3 months, and then you know.
So it's okay if they ask for one, then they're usually okay with getting the DPTP or NHIB altogether, one shot.
Yeah, well, these I said I find most of them will accept the 5-in-1, but they bulk the hepatitis B.
Okay. All right, let's go on, because there isn't an easy answer. And maybe what you might say at 2 months is different than what you might say at a 4-year-old visit. So, okay. So here's another one. We've had a little bit of chat about HPV tonight. So 13-year-old Robin has not been immunized against HPV. What do you do? How would you respond? What would you recommend?
I talk about HPV a lot.
Then tell us what you say.
Well, I see Robin could be a boy or a girl, so that's
yes.
good. And ask Robin and his or her parents what the reason is. Oh, it was free when you were in grade 6. You know, it could be because Robin has needle phobia, because that's pretty common in grade 6, and then we'd have to talk about that. It could be because parents still think that Robin's going to go out and have sex as soon as he or she gets HPV vaccine. Not quite, but it's going to promote early sexual activity. And as we discussed last week, it's now been demonstrated that that does not occur. And sometimes when you get out in the Fraser Valley in particular, some of the religious schools do not offer it. So I think there's a variety of reasons that Robin may have not had HPV. And I think the main thing is to reassure that, again, it doesn't encourage teens to have earlier sexual activity. In fact, likely the converse. Secondly, if you hurry up and get it, you only need 2 shots instead of 3. What was my third thing? I forget. 3, whatever. I forget what my third one was. Jane probably knows what my third one was.
And there's apparently a publication, which I haven't seen yet, from the UK, that the kids who had their HPV immunizations as young teens, 12, 13, have more likely an 80% reduction in precancer changes.
Oh, yeah, that was my
versus
third
the
thing.
older
It's
ones.
to prevent cancer. That was my third reason.
There. Compared to kids that were vaccinated when they were 17 or 18, they have a much higher rate of pre-cervical cancer changes.
I think parents don't realize that 2 shots at 13 is better than 3 shots at 15. They haven't got that message. They say, why does my child need it at 12? So I discuss that. And I do discuss cancer, saying this is a vaccine for cancer. If this was a vaccine for breast cancer, we'd be pushing our girls through the door, right? So I just say it's common and warts, and I bring it into the office, but that's a pain. You have to special order, and so I'd like to see more availability in pharmacies, and
Do you ever get into the discussion of how much it would cost you if you were somewhere where if you age out of school age immunizations, and then you'll have to pay $500 to get this? I'm just asking you.
Yeah, I've mentioned that a few times. And it works better when you get it younger, and if you wait till you're older, you have to pay, and it's a few $100s.
And someone, I can't remember who told me this, but someone else talks about when they have the adolescent is one of them. They talk about genital warts.
Mm-hmm.
And that's enough generally for the adolescents to say, So,
I had brothers in the office on Wednesday. They were 13 and 16, and they both told their mom they wanted to get it.
That's great.
Yeah.
And just to sort of make an observation that the way you've approached these two cases is it really depends on the situation. So, find out the context. There's not one answer for every child, every family. You need to find out, what their concerns are, what the questions are, what's the rationale behind not being vaccinated. And, maybe the mom just didn't sign the consent form for
And I
that.
tried to say, maybe you want to be gay for a day and go to public health and get it for free, but my boys won't do that.
They don't have to now.
Yours wouldn't, mine wouldn't. I said, just go, we're pink. No. Come on.
That's funny.
Okay, we have time for one more. This is one that Jane gave me, so we have to talk about this one. So you asked the mother of Robbie, who's an 8-year-old, you asked the mother what vaccines Robbie has last received, and she replies that he hasn't received any vaccines since he was a toddler. And when you recommend vaccines, she turns to Robbie and she says, "What do you think? Do you want to get your vaccines today? Do you want to get a shot today?" Then how do you respond? How do you manage that other than sending them to parenting classes and appropriate answers and decision making for an 8-year-old? And who's had that? You've had it.
Yeah.
And you've had it as well. And how do you manage it?
I don't have a standard way of managing it.
Again, though, that's what we're coming
Years
back
ago,
to.
The mother was absolutely convincing me, and I kind of, it wasn't 8 when he was like 4. And I sort of, between the two of us, we just held him down and did it. I physically restrained him and just gave it.
Yeah.
But, yeah, I don't know, it's a tough one.
Yeah. Because you don't want to question their
It's just
whole
the dumbest kind of
parenting
parent
skills,
who
right?
asks
And
a kid permission for things that they shouldn't be making decisions about.
exactly, like what's appropriate and yeah.
It's like,
Yeah.
would you like to get up from the exam table? No!
Goes around back to the talking about how to frame a vaccine. It's not, so what are we going to do about vaccines? It's, okay, today's the day. We're doing your vaccines
Do you
today.
want both vaccines in?
This arm or
One
one in
or-
one?
Yeah.
One in each.
Yeah.
How do you want to do this? That's the part you get to have a choice on.
Yeah.
Yeah. Any other comments on that?
I think also what's really interesting is the number of teenagers. There are a couple of teenagers in my practice, whose parents have never vaccinated them, but the number of teenagers who are actually secretly going off and getting all their vaccines.
Oh.
And
Now,
in the
isn't
United
that
States,
great?
they're actually paying, they're saving up their money and they're paying for those vaccines.
No way.
Oh, yeah.
Wow.
It's a really interesting phenomenon.
Yes, I must say, when I ran around the spinal cord clinic like 2 years ago, there was one family who was a really nice family, but the mother was an absolute anti-vaccine. So it was on his graduation day from the clinic. He's 17, it's year 12. And so I said to him, by himself, of course, I said, "Lou, it's now your life. You're going to make a lot of decisions for yourself right now. And one thing is you can decide now is you're going to get yourself protected with vaccines. So you got to go make this, it's an important decision. You go decide." Well, I never got any feedback from them. I'm sure she was livid at me. You know?
Well, yeah. Too bad that clinic that Jane's in wasn't open and running. Then you could have just sent him down there. Okay, I think in the interest of time, because the first two cases I think were pretty well covered in the discussions earlier. So what we're going to do next very quickly is the commitment to change, which is on our poll everywhere. So get your phones out. Then very quickly, we're going to do the post-test because I think our numbers are dwindling. And then before you leave this room, the evaluation. It's only 9, really. That clock is a little, or 2 minutes after, I think. Okay, okay, this is the post-test?
Yep.
Okay, so we'll do the post-test first and then we'll do the, yeah. Okay. Yeah, I had it put across to the top of each screen. put show results, yeah. Okay. Okay, we've only got one result in, come on.
I can't do it. We're doing it in our heads.
Okay. All right, excellent. In my little pile here. Okay. 9 results. Excellent.
Are we supposed to press clear last response?
No, you keep going. The questions should keep coming up. You have to enter your answer. Okay, let's just clarify. Pediatricians are required to report any adverse events following immunization if you're the person that hears about it or finds out about it. So if you're not sure, then I guess probably you would have your MOA or somebody check back with the family physician's office, or just make sure it does get reported. Not a sore arm, but just like as Julie mentioned. Limitations of passive surveillance. Okay, let's see those results. Excellent. Okay. So we had that one, right? Yeah, show results. Oh. Okay, that's all right. I'll fix it. I'll fix it. It's all, yeah. Okay, show results. Fantastic. And use your words, as I tell my toddler grandchildren. Okay, lack of trust. Okay. That's actually true. I'm sure somebody just hit the wrong button. Okay, number 9. There they are. Excellent. It's actually 2%, just to clarify, but 5's not bad. 2 to 3 probably, eh? So the answer should actually be D. Public health nurses and physicians. Pharmacists can immunize age 5 and up in BC. Excellent.
I think we've done this.
Yeah,
we have done that.
Yep. We've done
Yep.
this.
Okay, so I think we're finished that part. So briefly, just what we're going to do is a commitment to change. And the reason that I am having this, or that I have this on here, is that because studies have shown that even in like a group setting like this, using electronic system, that clinicians that make a commitment to change, even using 3 or 4 questions, have about a 60 to 70% higher of implementation in practice. That's by self-reports at 30 days and 90 days after. So that's why it's being included. Okay, so that this should, no, not the evaluation, the commitment to change. There it is, 4. So I will routinely initiate immunization up-to-date discussions in my office or hospital practice. Well, preaching to the converted, obviously. I will recommend routine and other appropriate immunizations for my patients. Currently, I plan to, or I have decided not to. Yes, wonderful. I will refer patients to public health or their family physician or a pharmacist or BC Children's Family Immunization Clinic for vaccinations. Okay, so for any that aren't currently doing this, they do intend to in the future. And like I said, there's a much greater outcome of actual implementation by just as this simple exercise, according to studies that have been done. So now I'm going to ask you to do the evaluation. And while Jackie is bringing that up for us, I really want to acknowledge that you know that I couldn't have done this without you, nor could anybody else here probably without a lot more thought. So thank you so much for that. Also, a reminder that the BC Pediatric Society website has a, not because I've been involved in it necessarily, but you've had other people here very involved in handouts for physicians and handouts for, is that the cutoff?
Someone just.
Or somebody just
Just
clicked
gone.
off?
Yeah,
Oh,
yeah, yeah.
Okay, that's fine.
That's fine.
So just continue on, just do that. This is not being shown. This is all, what's that?
Oh, good.
Yeah, no, we're not showing those. We don't even have to have it on the screen,
Yeah,
really.
we're gonna put it down.
Yeah.
Okay.
So just complete the evaluation. It's all confidential. But BC Pediatric Society website has excellent resources for families and for physicians. So that obviously the physicians is much more detailed. I'm just trying to think of, so there's, of course, HPV, there's meningococcal, specific to Men-B for parents, what parents need to know. What else do we have? Non-publicly funded vaccines, how to refer kids or families to get their vaccine if you're not an immunizing physician. There's several there. What are the steps? How do you do it? So I would encourage you to use those as well. You can either print them out if you have that capacity when you're seeing patients, or the tear-off sheets that you received for the HPV vaccine that were sent out. They were sent out to every pediatrician in October. On that, it has the credible websites as well. So that's an easy takeaway for a parent. It doesn't always have to be about the HPV. The websites are still good. So in addition to, and Immunize BC is included on there as well as several others, but just that you do have something. Yeah. And you're going to thank our wonderful speakers, right? And everybody for coming in.
Yes.
Okay, I'm sitting down there.
Thank you to those who are still hanging in here. And thanks to our excellent speakers, Dr. Julie Bettinger and Dr. Rika Gustafson and Dr. Jane Finley. And especially thanks to Laura for organizing this whole evening